out. I request Dr.Thiyagarajan Thangavelu sir, diplomat in internal medicine in USA, diplomat in endocrinology, diabetes and metabolism, USA, a consultant endocrinologist in PhD IMSR, Coimbatore, to present his valuable insights on the topic evaluation of hypothalamic adrenal axis. I request the chairperson, Dr. R. Shanmugavadivu ma'am, MD Physiology, Professor and Head, Department of Physiology, Coimbatore Medical College, to introduce the speaker and chair the session.
A very good morning to all of you. At the outset, I would like to congratulate Dr. Deepalakshmi and her team for organizing a wonderful CME. And I thank Dr. Deepalakshmi for giving me this opportunity to chair this session. I am indeed privileged to introduce to you all Dr. Thiyagarajan Thangavelu, consultant endocrinologist from PhD Institute of Medical Sciences and Research. Sir has done his bachelor's MBBS from Stanley Medical College, and then later on internship and residency from the St. Francis Hospital, University of Illinois, United States of America. He has done his fellowship in endocrinology from the University of Nebraska from the United States of America, and he has a lot of certifications and licensure from the American Board of Internal Medicine, American Board of Endocrinology, American Board of Obesity Medicine, Certificate of Clinical Dentistry, and Tamil Nadu Medical License. He has a lot of work experience to his credit, and he has worked in St. Elizabeth Hospital, United States of America, Mayo Clinic, USA, from Holy Family Medical Center in Chicago, and he has worked in Chennai also. Sir has got a volunteer experience in certain areas in the United States of America, and he's a professional member of the Endocrine Society, American Diabetes Association, American Academy of Clinical Endocrinologists, International Society of Clinical Densitometry, and American College of Physicians. He has to his credit a lot of administrative roles, like being the member of the Physician Recruitment and Retention. And he has teaching experience at the University of Nebraska, USA, Mayo Clinic, USA, University of Wisconsin-Madison, USA, University of Iowa, USA, and University of Illinois at Chicago. He has a lot of credits being the house officer of the University of Nebraska Medical Center, and he has received the Best Fellow Poster Award at the University of Nebraska, and he has been invited to compete in the Endocrine Society of Presidential Poster Competition at USA. With all these credits and credentials, he has a lot of publications to his credit in many reputed journals. He has done a lot of oral and poster presentations, both at the national and at the international level. So with a huge round of applause, let me welcome Dr. Thiyagarajan Thangavelu to deliver the speech on evaluation of the HPA axis. Welcome, sir.
Thank you, ma'am.
Thank you. Good morning, everybody. And I thank Coimbatore Medical College, Department of Biochemistry, and everybody who's here for inviting me for this, this lecture today. I think the theme is precision medicine. So we'll stick to the theme as much as possible. So let me just get started with the talk here. So these are some of my disclaimers. So some of these are already been discussed by Dr. Swami sir. So I will be repeating a few things. Please bear with me in those regards. The first thing is I don't have nothing to disclose. I don't have any financial or otherwise any conflicts regarding this lecture. I'm a clinician, just like Dr. Swami sir said. You know, mostly this talk is going to be a clinical talk. So if you ask me anything deep about biochemistry or physiology, then I would not be able to answer. But I think that's what matters here. You know, that's what you're learning now, and that would be very important. This lecture here is meant for everybody. There's something for everybody, for first year students here, for clinicians here, for PG students in biochemistry, physiology, and also in medicine. So, I don't use SI units. I only use conventional units throughout this talk. And that's what is common in practice. So that would be useful for you as well. So just like Dr. Swami sir said, availability of test varies. If you order a test, you have to understand whether this test is particularly available from where you are practicing, and it may also vary from place to place and also time to time. Say, for example, today we're going to talk about the evaluation of the adrenal axis. An important test is called the ACTH stimulation test, and that test may not be available during some periods in time. Like say, for example, 2 years ago, we had the availability of corticotropin. So we could do the ACTH stimulation test in practice, but now it's not available. So we have to adjust to the availability of the test as and when required. Next is reliability of your lab. And again, this is something Dr. Swami sir addressed during his first talk. You should be able to know your lab, the lab you're sending your test to. If the lab is doing a good job, if they do the latest assay, if the machine is reliable, the person who's doing the assay is reliable, then you can interpret the results correctly and focus on your management accurately. But if the lab provides you with an error value, just like the first case Dr. Swami sir said, where the TSH was reported as normal, or when they were manually entering the lab values, they switched between the T3 and TSH, then it's prone to error, and that would lead to clinical error as well. And finally, what the Greek philosopher Heraclitus said, change is the only constant. So whatever I am going to say during this talk may change over the next few years. Even some values that what I learned during my training, say for example, the maximum response or the minimum response you need in a ACTH stimulation test used to be 18 microgram per deciliter. And now the latest assay, after the introduction of the latest assays, these values have changed. And the same thing could change in the future as well. So, lifelong learning is important, and that was, said earlier, and that's the purpose of the CME. These things change, so you should keep yourself updated even after you're finishing your course. Now, let's go into some of the basics. These are basics for all endocrinology diseases. First thing is you should be able to distinguish between what is normal physiology and what is clinical disease. Again, like say, again, Dr. Swami sir had this particular slide, but he didn't talk about it much. There's something called CQ thyroid or abnormal thyroid function in non-thyroidal illness. You should be able to recognize that. And, only then you would be able to understand what is disease. So if you know now what is normal, then you would know what is abnormal. Next is whenever you're evaluating a hormonal disorder, there are two kinds of tests you do. One is static test. Static test means like, you're measuring a hormone level at a certain point in time. And the results can be either low, or it can be high, or it can be normal. If you remember Dr. Swami sir's second case of thyroid, the T4, T3 were low, but the TSH was normal. So was the TSH appropriately normal or inappropriately normal? That's the question you should ask yourself, because the clinical picture shows that the patient may be having a low thyroid function, but the TSH is normal. So that's when it comes to whether it's appropriately normal or inappropriately normal. Same thing is about, like, say, for example, a classic example is calcium balance. Calcium is regulated by which hormone? Can one of you answer? Which hormone regulates the calcium levels in the blood? PTH, right? Okay, so, when the calcium levels are low, the PTH level should be high. When the calcium levels are high, the PTH level should be low. That is the negative feedback. So, if the calcium levels are high and the PTH is still normal and it is not low, so what means that it's inappropriately normal, then that means there's a problem there. So normal is not just normal in endocrinology. So it should be whether appropriately normal or inappropriately normal. So it should bear with this on this concept also. Now going into dynamic testing. So, sometimes just static testing may not be helpful. Say for certain diseases such as the thyroid, static testing may give you the answer. So if you suspect hypothyroidism, the TSH is high, the T4 is low, then you got your diagnosis of primary hypothyroidism. But not all endocrine organs behave that way. So you may have to do something called dynamic testing. And that's because many of the diseases are not all or none phenomenon. So they can be, subtly low. So you may have to wonder whether it is subtly low or is it really normal. So in those situations, you may have to do what's called dynamic testing. So dynamic testing means that, if you're, you have to wonder if the patient has suspecting a low functioning of a gland. If you suspect a hormone levels are low, then you should do a stimulation test. What it means is that you have to create an environment or a situation where the gland gets stimulated maximally and see if the gland is able to secrete the particular hormone to an adequate level. So if you suspect a gland to be hypofunctioning, you do a stimulation test. And if you suspect a gland to be hyperfunctioning or secreting too much of a hormone, you try to suppress with a medicine or a situation and see if the hormone levels would go down. And that's why you need to know your physiology and your biochemistry to know what things will stimulate a gland, what things will suppress the gland. Again, this was mentioned in the earlier talk also. Like say, take an example of adrenals. If you give steroids from outside, the adrenal glands will be suppressed, right? So that's the basis of the dexamethasone suppression test. So that is, if you're suspecting that there's too much of the gland, there's too much of the secretion of the cortisol, then you give an exogenous steroid and to see if the gland gets suppressed. Same way the stimulation. What would stimulate the adrenal glands to make more cortisol? Any kind of stress situation will make the entire axis, the hypothalamus, even before the hypothalamus, the frontal cortex and the CNS, the hypothalamus, then the pituitary, then the adrenals. The whole system will get stimulated in any kind of stress. How would you create a stress in a clinic, in a clinic or in a hospital setting? So one way to do that is to make the patient hypoglycemic. So you give insulin voluntarily to a patient, make the patient hypoglycemic. So you stress the patient, they try to stimulate the entire axis. That's the basis of the insulin tolerance test. We'll go into that later. You should be, at least aware of the methodologies of the hormonal assessment so that you would be able to interpret them correctly. And that becomes important because you should be able to know which assays are done in particular hospital. Like say, for example, where I practice, the cortisol levels are measured by a machine called Roche, and the assay they use is called Eclysis cortisol 2 assay. And so I would know what would be the normal values for such an assay. So in the same way, wherever you're sending your lab reports, you should be able to know which lab and what test they are doing, what assay they are doing. And in the endocrine evaluation, you should also know about binding proteins. So many of the hormones are steroid hormones. So they are very lipophilic. So they don't get transported in the bloodstream easily. So they don't go from one place to another all by themselves. So they need to be bound to something else where they can dissolve in the blood and get transported to the target tissue. So anything that's a steroidal hormone or a thyroid hormone would need to be bound to a protein. And most times it's a specialized binding protein.
Now, some of the causes of secondary adrenal insufficiency. The most common cause is exogenous steroid use. Patient may be using steroid for whatever reason, maybe for a neurological problem, maybe just for joint pain, because of complications, asthma, skin condition, or whatever reason the patient may be getting access of steroids, or sometimes people take API medicines, and some of these API medicines are inadvertently laced with steroids, and that can cause the secondary adrenal insufficiency. The second common cause is the pituitary tumor. Again, there are some cases here. One is pituitary tumor. The next one is surgery. Again, a surgery for a pituitary tumor. Whether the patient has bleeding into the pituitary. The patient might just recently last week yesterday. He was diagnosed with a small pituitary tumor several years ago. He neglected it, and last week he had severe headache. So we are bleeding into the pituitary tumor. That's all the organs. That's the one. Secondary adrenal insufficiency. Next is hypophysitis, where there is the postpartum stage is called postpartum hypophysitis, or inflammation of the pituitary gland. There's nowadays there's immunotherapy for early pregnancy such as lymphoma, renal cell carcinoma, and so on. These immunotherapies, what they do is they revoke the immune system to target the cancer cells, but they also have some unwanted side effects, and some of them may increase the antibodies across certain cells. Okay, so now let's go into cortisol.
Cortisol levels, always check cortisol levels. If you want to have a basal cortisol level, check them in the morning before 9 a.m. Most labs don't open by 7 a.m. So you can check that the most by 8 a.m. So cortisol levels have a diurnal variation. They are secreted more in the morning and the levels go down as the day goes by. So the most level you will see is in the morning. So when you want to have an adequate check whether the adrenal is making enough cortisol, you have to check it in the morning. After that, every hour, about 1 microgram per deciliter of cortisol level goes down for every hour. So you can imagine by 3 p.m., even if the morning values are like say 18, by 3 p.m. you're already down to 9. And by 9 p.m., they're almost 0. So that's what you have to understand and remember. So cortisol levels goes down as the day goes by. So if you have to check a basal level, check it in the morning. So what are the assays done? Most of the assays we use here are automated immune assays. Again, don't ask me too much about this. So they use competitive binding. So they have an antibody to a particular hormone and they have another tracer that measures the hormone level. And what are the disadvantages of this? Patients may have other antibodies present. Say patient has rheumatoid arthritis or SLE. Other antibodies may interfere with this system. There may be cross reactivity. Because the newer systems, such as the one I talked to you about, the Roche Eclysis 2 cortisol assay, they are very specific to cortisol. But some of the older assays may have cross reactivity to other steroids, so you don't have an accurate result. Third thing is biotin. People now take biotin for hair growth, for hair loss, they take biotin, and some of these assays are biotinated assays. So if there is too much biotin in the system, that can interfere with the results. Just be aware. And other types of assays are gel chromatography and mass spectrometry, and liquid chromatography and tandem mass spectrometry. These are very analytic specific assays. So they will measure the thing, exactly the thing you wanted to measure. So these are very, very specific, but that may be a disadvantage. I will tell you later why. So again, coming to basal cortisol, if the basal cortisol is less than 3 microgram per deciliter, you already had your diagnosis. There is not enough cortisol in the system. So less than 3, it is already made the diagnosis. If it's more than 18, it is normal. Something anywhere from 14 to 15 also, if it is high, it is normal. But when you are checking adrenal insufficiency after, say, a pituitary surgery or a pituitary problem, then if it's between 3 and 12, you can be sure that if it's more than 12, it's enough. If it's less than 3, you already know it is normal. I mean, it's low, so you can already start the steroid replacement. So you don't need to do any further testing. But it's only between 3 and 12 you have to make the testing, especially if it's between 3 and 7.7, you should definitely do a test. And if it's between 7.7 and 12, you suggested to do a test. If the patient is on exogenous steroids, say if the patient was given steroids for pemphigus vulgaris, it's a skin condition. Okay, it's an autoimmune skin condition, for example, and was given steroids for 3 months. And you want to check, and then the dermatologist thinks that the patient has had enough treatment, he's getting better, he doesn't need steroids anymore. But he or she is worried that whether the patient has enough adrenal reserve. In that situation, if you check a basal cortisol, if the basal cortisol is more than 8.8, you can be sure that the patient has enough adrenal reserve and you don't need a replacement dose. So again, this is where the precision medicine comes. For different situations, you use different cutoffs to make a clinical judgment and clinical decision. Now, after pituitary surgery, say if the patient gets a surgery for craniopharyngioma or a non-functioning pituitary adenoma, and you are wondering if the patient would go into hypocortisolism or adrenal insufficiency after the surgery, again, precision medicine, the second post-operative day, if you check a cortisol level and if the cortisol level is more than 10.8 microgram per deciliter, you can safely say there are enough corticotrophs left and to stimulate the HPA axis and have enough adrenal reserve. Now, measuring the ACTH. ACTH is a highly sensitive two-site immunoradiometric assay, or what we call a sandwich assay. Again, I won't want to get into the technical details because I know not very clear itself. The normal range is 10 to 60 picogram per ml, very, very tiny levels. So we said cortisol is measured in microgram per deciliter, aldosterone in nanogram per deciliter, and ACTH in picogram per ml, very low levels. And if you have the ACTH level less than 3, and if, the cortisol level less than 3 and the ACTH level more than 100 or 120 or two times the upper limit of normal, you can make a diagnosis of Addison's or a primary adrenal insufficiency right away. So that is the value of ACTH here. In an acute crisis, say if the patient comes in, like say if the patient is like Dr. Swami said, like a patient is going to die in the next 24 hours with hyponatremia, with low blood pressure, or patient had a traumatic head injury and is in the ICU and is having low BP, you don't have time to check if the patient has adrenal insufficiency or not. Or if the patient rapidly went into sepsis, came with a pneumonia, but went into rapid sepsis and they're wondering whether the patient has enough adrenal reserve, don't wait for doing any testing. You just go ahead and start steroids. If you have time, you can check for cortisol and ACTH. You can just send the lab. Don't wait for the results. Start the steroids right away. Now let's go into one of the stimulation tests. So the commonest stimulation test that you will learn for any endocrine testing is this ACTH stimulation test. It's called the high dose ACTH stimulation test or a standard ACTH stimulation test. So what do you do? Where do you use it? You use it to diagnose primary adrenal insufficiency, and sometimes can also be used in chronic secondary adrenal insufficiency. Why not in a acute secondary adrenal insufficiency, or why not in a partial adrenal insufficiency? Because the adrenal cortex may still be able to stimulate the adrenal cortex may even be able to stimulate it when you're using supraphysiological doses of ACTH, and that's what we do. First, to measure a cortisol and ACTH, you give 250 microgram of the post-intropin, which is the synthetic ACTH. The natural ACTH is a 1 to 39 peptide molecule. This one is a 1 to 24 molecule. Mostly we use IV bolus. Some centers do use IM, but we use IV. So this makes the ACTH levels to go to very high supraphysiological levels. You can see on the screen there, 1,000 to 60,000 picogram per ml. Just for comparison, the normal levels are 10 to 60. So you create such a high ACTH levels in the blood to see whether if the cortisol will respond to such a high stimulus. You measure a cortisol level in 30 to 60 minutes, and if the cortisol levels are more than 18 microgram per deciliter, that you call it is a normal response. And that's what I learned. That's what's been used in practice most places. But the newer assays are even more specific for cortisol. And like the one assay I told you about, the XSS2 assay, or any of the mass spectrometry assay, even with the 13.5, you can rule out the adrenal insufficiency. If the adrenals are able to make cortisol levels of 13.5 micrograms per deciliter after a stimulation using a high dose ACTH, you can rule out adrenal insufficiency. There's something called actin prolongatum. Again, the first slide I told you in the disclaimers that the availability of test may vary time to time and place to place. The synthetic ACTH is not available currently. So we are not able to use it. So there's a alternative, something called actin prolongatum. I am not using it as of now. It's a porcine molecule. It's also a synthetic corticotropin, but it comes from a pig or a porcine molecule. So it comes in a 60 units per ml vial, and you give 25 units IM using an insulin syringe, and then you start measuring cortisol level. Again, a cortisol level of 18 microgram per deciliter is considered a normal response. There are many studies from India that have shown that this can be used as an alternative to a normal ACTH stimulation test. Again, we don't have ACTH currently available. That's why we are using this. Now, when do we use a low dose ACTH stimulation test? Again, I told you, when you use a standard or a high dose, you give very high supraphysiological dose of ACTH. So that may stimulate even a partial or a somewhat affected cortex. So you have to use a very low dose ACTH stimulation test if you're trying to diagnose very subtle signs of autoimmune, adrenal insufficiency, or in exogenous steroid use to see determined adrenal reserve, or if the patient has autoimmune polyglandular syndrome type 2 or a Schmidt syndrome, where the patient has antibodies to different endocrine glands, including the thyroid, the ovaries, and the adrenals. The patient may be presenting only with hypothyroidism and primary ovarian insufficiency, but if you check the adrenal antibodies, they may be high, but the patient may not have clinically exhibited any signs of adrenal insufficiency yet. In those cases, you may use a low dose ACTH stimulation test. We don't normally use this because it's a very cumbersome test, because you have to dilute 250 microgram, which is present in 1 ml, into 1 microgram. So you have to dilute it by 250 times, which is very difficult clinically. And that's why most people don't do this test. But just for your knowledge here, if you do this test and if the levels come back as more than 20 microgram, it's a normal response. Now coming to insulin tolerance test, again, we talked about this in the first slide here. You create a situation where there's a stress to the entire creature. Entire organism is stressed. So the entire system, the hypothalamus, the pituitary adrenal, the entire axis is stressed. How do you do that? You make the patient hypoglycemic voluntarily. Many people don't do this because it's a scary test to do. I've done a few tests during my career here, but it's very tough test to do. You have to be very careful in doing this test. So, what you have to do, this is considered the gold standard test for testing the anterior HPA axis. If your patient has history of seizures or coronary disease, or if your patient has any arrhythmias, you should not do this test. Because if you make the patient voluntarily hypoglycemic, you can precipitate any of these conditions, which can be lethal to the patient. So you got to be very careful in doing this test. So take necessary precautions. You should have a very trained nurse. You should have dextrose, something to eat. You should have glucagon, and you should have ice ready because ACTH is kept on the tubes are kept on ice so that you get the reliable value. So you give regular insulin 0.1 unit per kilogram IV. Patients who are already diabetic or may have insulin resistance, you may even give a double the dose. Watch for sympathetic symptoms such as sweating, tremors, shaking, and then watch for neuroglycopenic symptoms, meaning the low blood sugar is affecting the patient's ability to think or the functioning of the central nervous system. The patient will start getting confused, start having headaches, and if you are not careful, the patient may go into comatose. So once the patient starts getting any of the headache symptoms or slightly dizzy symptoms, then the patient is getting neuroglycopenic symptoms. You should start checking the glucose. You should be checking the glucose levels capillary in every 5 minutes and sending the levels from the plasma every 15 minutes. When the glucose levels reach 40, sometimes you can stop it at less than 50 also. And then you start send the measures for both the cortisol and sometimes you also check the growth hormone levels. If you want to check the hypothalamic, pituitary, and growth hormone axis also, the insulin tolerance test can also be used in that situation also. Here also the results are, if the cortisol levels are more than 20 microgram, it's normal. If it's less than that, then it's abnormal. Now I'll just show you this slide. This is the steroidogenesis pathway. I won't go into this detail. This is a very cumbersome slide here. I don't think you will all learn it. You may forget it. You may again learn it just the day before your exams, and that's what I do as well. Why am I showing this? I just want you to, because of the next slide, I want you to look at this here. This particular enzyme called 11-beta hydroxylase. This converts 11-deoxycortisol into cortisol, and that's the reason I'm talking about this slide here. So there's something called meteropone testing. Like I told you, this insulin tolerance test is not able to be done clinically for many of our patients because of the dangerous conditions it is done. So an alternative is something called meteropone testing. Again, this test is not available in India. Maybe you can get it available by specially ordering it, but I have not done it. So what does meteropone do? The meteropone blocks this last enzyme in the pathway, which converts the 11-deoxycortisol into cortisol. So 11-deoxycortisol into cortisol conversion is affected. So the cortisol levels will be low, but the 11-deoxycortisol levels will go up because the 11-deoxycortisol will stimulate the hypothalamus and the pituitary. So the CRH and ACTH will be normal. So if the axis is working good, if you give meteropone, the final step alone is blocked. So cortisol levels will be low, but the 11-deoxycortisol level should go up. That's the basis of this testing. So meteropone is given as a 30 milligram per kilogram dose at night. The next morning you check a cortisol, ACTH, and 11-deoxycortisol. It's measured using a tandem mass spectrometry method. If cortisol levels are low, 11-deoxycortisols are high, then it means the entire HPA axis is working good. If it doesn't go this level, if the 11-deoxycortisol level is also low, then you have a problem. Something called free cortisol. In some cases, the CBG levels may be altered, like we talked about earlier. The binding protein levels are altered in certain conditions such as pregnancy, patient is taking a birth control tablet, patient has nephrotic syndrome, is using androgens, testosterone injections for whatever reason, has liver disease, the binding protein levels may be altered. So you may want to check a free cortisol. Again, free cortisol is only now done in a research setting, not available for clinical practice, but it may come in the clinical practice very soon because it's very, very valuable tool sometimes in the ICU settings. So by the time you are all going to be in practice, this may be available here. So it does done using either a equilibrium dialysis or an ultrafiltration, and then you do a liquid chromatography and a tandem mass spectrometry. So the levels are 0.9 and 1.3. If it's above these levels, it is normal. Now, some of the miscellaneous tests here, salivary cortisol, again, this is not available. It's not a routine test we do, but we have the capability of doing these tests. Especially we use it for Cushing's, not so much for adrenal insufficiency, but in certain developed nations, people go get tested on salivary cortisol themselves without a doctor's prescription, and they may come. This may happen in India as well sometime in the future, and the patient may come to you with the salivary cortisol level and asking you to interpret it and say if the patient has an adrenal insufficiency, then you may have to interpret it. So salivary cortisol is a free cortisol because it's not bound to the globulin. So you check it in the morning level, and if it's less than 1.8 nanograms per ml, then it's likely that the patient may have adrenal insufficiency. If it is more than 5.8, it's less likely. You can also check urinary cortisol. Urinary cortisol is also free cortisol filtered to the glomerulus, and that low also can happen in adrenal insufficiency. There's anti-adrenal antibody, and there's 21 hydroxylase antibody. If the patient has primary adrenal insufficiency, and if you're not sure if the patient has Addison's disease or if the patient has something else such as malignancy or TB or sarcoidosis or hemorrhage into the adrenals, then you might want to measure the 21 hydroxylase antibody. And if that is high, then it proves the Addison's. So I'll just go into the next case here. We are moving away from adrenal insufficiency into Cushing's. So it's a 56-year-old female. She is admitted with wrist fracture after a fall. She has obesity. She has found to have striae in her abdomen. And she has a supraclavicular and dorsocervical fat pad and fullness. And Dr. Swami sir also mentioned this like a lemon on a stick or a orange on a stick. Again, we don't use those terms anymore. And we don't use terms such as, moon faces or buffalo hump. So we should be using proper technical terms. So round faces with plethora, and patient has central obesity with thin limbs. And again, that's how you should mention and not mention like lemon on stick anymore. So you check your cortisol level. Cortisol levels are actually low. So what does it mean? The patient has all the features of a Cushing syndrome, but the cortisol levels are actually very low. Exactly. So exogenous Cushing's. So if the patient is taking steroids from outside, so has all the features of a Cushing syndrome, but the endogenous system, the HPA system is suppressed. The patient actually has secondary adrenal insufficiency, but because of the exogenous steroids, the patient is having Cushing syndrome. So we'll have a few slides on Cushing syndrome. Most of the HPA axis evaluation is for adrenal insufficiency, but I do have a few on the Cushing syndrome as well. So what are some of the causes? ACTH dependent, it can be Cushing's disease, which is a corticotroph adenoma in the pituitary gland, or it can be ectopic ACTH. Just like the last case of Dr. Swami's discussion, the patient had a bronchogenic carcinoma, which was operated and all her symptoms got resolved, and other things such as bronchial adenoma and so on. Now, ACTH independent ones, you have exogenous steroid, that is the most common cause. Then you have adrenal adenomas, then you have adrenocortical carcinomas, which are rare but can, and then you have the primary adrenal macro and micronodular hyperplasia. So there are two phases of evaluation for Cushing syndrome. The first phase is diagnosing the disorder. This is the most challenging part because the patients may come with subtle signs of Cushing syndrome. Patient may be obese, may have weakness, fatigue, and all that, but it may not really be Cushing's. It may be pseudo Cushing's. The patient may be, either having alcohol abuse or withdrawing from alcohol, and that may all appear like Cushing's, but it's not Cushing's. Obesity is such a common problem nowadays, so you may be wondering whether the patient has Cushing's, but again, clinical suspicion is the most valuable tool, and that is where precision medicine comes. If your clinical suspicion is high that the patient really has Cushing's, do further testing. And if you think the patient has just simple obesity, don't do very expensive testing. Sometimes the patient may be having mild forms of Cushing's, maybe early forms of Cushing's, or something called cyclical Cushing's. In those situations, you may want to test more and more. Next part of the evaluation is diagnosing the etiology, meaning whether the Cushing's is ACTH dependent or independent, and whether it's central or ectopic, meaning whether it's a pituitary problem or it's an ectopic and so on. Then you find the localize the lesions. Now, what are the principles of testing? Hypercortisol. Cushing's means more cortisol. Next is loss of circadian rhythm. Like I told you, cortisol levels are high in the morning and go slow as the time goes by. And by night time, it should be undetectable basically. But if this rhythm is lost, then you have Cushing's. Next is loss of normal feedback mechanism of the HPA axis. Then that's the basis of the dexamethasone suppression test. When you give exogenous steroids, the cortisol level should be low. If it doesn't get suppressed, then it means Cushing's. Okay, so urinary free cortisol test. So 24-hour collection because eliminates the circadian variability. So you're collecting the urine for 24 hours so that you get the 24-hour cortisol production. Next, free cortisol is filtered and majority is reabsorbed. Only a small portion is excreted. But in Cushing syndrome, this levels is very high since the CBG has a very limited capacity. Only up to 25 microgram per deciliter is bound to the CBG. Anything above that. So in the case of say a pituitary adenoma that makes ACTH or an adrenal adenoma that makes a lot of cortisol, there is too much cortisol in the system. So most of it is already bound to the CBG. The rest all gets filtered to the kidneys and excreted in the urine. So if you measure the urine and if there's too much of cortisol, then you make the diagnosis. Next, the sensitivity is high. You can check it using again high performance liquid chromatography, tandem mass spectrometry. But a radioimmunoassay is commonly used also, which can have interference. And the specificity will increase if the upper limit of 4 times the upper limit of normal is seen on the results. Less than 45 unlikely, more than 200 most likely. Proper collection is needed. Creatinine should be normal. In pseudo Cushing's also can be sometimes abnormal, so you got to be careful. Excess fluid intake may dilute the specimen, so you got to be careful of that as well. Next is midnight salivary cortisol test. Again, circadian rhythm. Based on the circadian rhythm, at midnight the cortisol level should be basically undetectable. But if the levels are high, then you make a diagnosis of Cushing's. So you check a salivary cortisol. Serum free cortisol is not easy to measure, and that's why we measure a salivary cortisol. Saliva does not have CBG, so it's the whatever the cortisol is in the saliva, it's all free cortisol. So you don't have to do a very expensive equilibrium dialysis and ultrafiltration and so on. You can do a simple cortisol assay using the salivary specimen. It's convenient to do because all the patient needs to do is spit into a tube and give it to you next morning, and you check the cortisol level. And these are different methods it gets done. And if the levels are more than 100 nanogram per deciliter, you have a suspicion. If it's more than 200 per deciliter, then the diagnosis of Cushing is likely. Again, high sensitivity and specificity. And midnight workers, night shift workers, jet lag, depression, these things may alter the levels because the circadian rhythm is affected. So you can't do those tests in these particular situations. Now coming to dexamethasone suppression test, this was again Dr. Swami said this in the earlier discussion. You give 1 milligram of dexamethasone at 11 p.m. the night before, and that should suppress the entire axis. The HPA axis should get suppressed. If it doesn't get suppressed and you check a morning cortisol and if the levels are more than 1.8, then there's a problem here. If you keep the level at 5, your specificity increases, but your sensitivity will go down. So usually I don't do this as the primary test. If my pre-test probability is high, I don't do a dexamethasone suppression test. Only if my pre-test probability is low and I want to rule out Cushing's, then I do a dexamethasone suppression test. That's where the precision medicine comes in. That's why the clinical suspicion is important. If your clinical suspicion is high, check a 24-hour urine-free cortisol or check a salivary cortisol. Only if your clinical suspicion is low and you're just trying to rule out a problem, you do a test with more sensitivity but less specificity. You do a dexamethasone suppression test, and if it comes to normal, then you rule it out right away. So sensitivity is high, specificity is kind of low. And the positive predictive value depends on the population you are testing. The other things that may alter this test results are medications that may metabolize the dexamethasone faster. So this is a slide that shows that all the tests we talked about, either the dexamethasone suppression test, the urine cortisol, or the bedtime salivary cortisol, all these tests have some factors where it can give false positive or false negative results. Why is it important? Because no test is perfect when you're evaluating Cushing's. So one single test is never enough. You need more than one test to make a confirmation or a diagnosis. And if your clinical suspicion is high, you keep testing periodically. So again, coming to the precision medicine, your clinical suspicion is the most important tool. If you have a high suspicion, keep doing the test, keep doing different tests to make the diagnosis. But if you're low, your test is if your pre-test probability is low, stop with one test or get rid of the confounding factors and repeat the test. So these are some of the other tests. Again, I will go through this very quickly. A low dose suppression test is used to differentiate between Cushing's and pseudo Cushing's. You give a very low dose dexamethasone for 2 days and you measure a cortisol level. In pseudo Cushing's, it gets suppressed. In real Cushing's, it doesn't get suppressed. And an overnight high dose test, this is done to differentiate between a pituitary adenoma that makes too much of ACTH versus an ectopic ACTH, because pituitary ACTH producing adenoma will get suppressed by a high dose dexamethasone, whereas an ectopic ACTH producing tumor will not get suppressed. So you give a high dose of 8 milligram of dexamethasone. Next day morning, you check a cortisol level, and if it gets suppressed, then it's a pituitary Cushing's. But if it doesn't get suppressed, then it's an ectopic Cushing's. And you saw that in the Dr. Swami's case, the ACTH level was 250, and that's where this comes here. You first confirm the Cushing syndrome. If you confirm the Cushing syndrome, check as the ACTH level. If the ACTH levels are undetectable, then the problem is in the adrenal glands. So you check a scan or image the adrenal glands. But if it's increased, even if it is normal, even if it is like say 40 or 50, and that's where inappropriately normal comes in. Even if it is normal, where it should be suppressed, so it is inappropriately normal, then the problem is not in the adrenals, it's above the adrenals. So you check a pituitary MRI, and if the MRI has a definitive tumor, like say if there's more than 6 millimeter and so on, then you already make a diagnosis. But if the pituitary either doesn't show a tumor, or if it's equivocal, or if it's a very tiny tumor, like say 3 millimeter, and you can't make a diagnosis, you may have to do a test called inferior petrosal sinus sampling. So this is the inferior petrosal sinus sampling. I'll just quickly say that again. Before you do this test, you have to be 100% sure that you have a diagnosis of Cushing's. Otherwise, you're putting the patient at risk for a very risky procedure. So again, precision medicine, clinical suspicion, then you do the laboratory testing. Once you make the confirmation, then only you have to go through this testing, because even in pseudo Cushing's, the IPCSS test may show a difference between the central and the peripheral. So you may let the patient undergo an unnecessary pituitary surgery for no reason. So got to be very careful here. So make the diagnosis, confirm your diagnosis first. So you have to measure the ACTH levels in the center, in the inferior petrosal sinus, as well as in the periphery, which is like the jugular vein. And the ratio should be either 2:1 or 3:1 if you also use CRH or desmopressin. And between the sides, for the left side and the right side, it should be at least more than 1.4 times to localize the lesion. Again, this may be something you don't need right now, because most of you here are, I think, are first year MBBS students. So I'll just go through the other things too. It's a very difficult test to do. You need a really an expert to do this test. So you may not be able to get it done most times. There's something called CRH stimulation test. Again, CRH is not easily available. CRH is given IV and measured. Next is a DDAVP stimulation test. Again, like I told you in the first slide here, that adjuvant vasopressin is co-secreted with the CRH. So this can also stimulate the pituitary corticotroph, and you can use this to differentiate between Cushing's disease and pseudo Cushing's. Thank you. Sorry, I took a lot of time, I guess, so I'll stop here.
Thank you, sir. That was truly an elaborate session.
Any questions?
The session is open for discussion. Any questions? You can ask the
Thanks for the excellent speech, sir. What's the role of cortisol in IMCU settings? Which subset of patients you will suggest to do cortisol?
Okay. So I think, there are two different scenarios we can imagine in an ICU. One is a common thing we encounter all the time, which is like a patient who's admitted with sepsis, like either a pneumonia or a UTI or any infection and went into sepsis. There is this concept called relative adrenal insufficiency, where you think that, the HPA axis is not mounting an enough response. There's not much cortisol in the system. In those situations, there are guidelines keep changing every few years. So, when we had the guideline directed therapy, then we had the surviving sepsis campaign. So every protocol, every decade had a different recommendation. But the recommendation is in basically, what I go by is that in a situation like that, you can measure a random cortisol level, and whatever the level may be, you can start the steroids. So go ahead and start the steroids, and you can always taper and stop it very quickly once the patient is improved. The other situation is, like the patient comes in with again hypotension, hypoglycemia, dizzy and all that, and you're really suspecting the patient has adrenal insufficiency. In those situations, either after like the case I told you, like a head injury patient, a road traffic accident has comes with a head injury, and you're wondering whether the pituitary is intact, or patient comes with a severe headache, you don't have the results of the imaging yet. You can say again in the same concept, you can send a cortisol and an ACTH and start these steroids. So in an ICU setting, don't hesitate, check, send a level, send the blood test, but don't wait for the results, go ahead and start the steroids.
You said intrapetrosal sinus sampling.
Yes, ma'am.
How do you do that? What is the approach you will go for doing it? That?
Yes, madam. So sometimes the neurosurgeons do it, sometimes the interventional radiologists do it. So they puncture the femoral artery and then they thread the guide wire up into the sinus, or they go through the radial approach. They go all the way up to the brain and reach the inferior petrosal sinus. They have one collection sample, one tube at the petrosal sinus, and some from the jugular veins, and from there they collect the samples.
Okay.
So it's a demanding procedure and can lead to many problems. That's why we very rarely do those tests.
Yes. What is the use of intrapetrosal sinus sampling? You said it is to differentiate between central and the peripheral.
Yes, ma'am.
I didn't get it.
Once you diagnose Cushing syndrome, so you already made the diagnosis of Cushing syndrome, and you check a ACTH level, and the ACTH levels are high or not suppressed or normal. So then it's because of the high ACTH, the patient is having Cushing syndrome. So whether it could be because of a pituitary adenoma that's causing the Cushing syndrome, or it can be because of an ectopic ACTH. So in ectopic ACTH conditions like a bronchial carcinoid or a bronchial adenoma, the ACTH levels are very high. So the clinical suspicion itself may be enough, but to prove the diagnosis, you do an MRI scan of the brain first. And if you see a definitive pituitary lesion, then it's most likely because of a Cushing's disease or a pituitary adenoma. But if you're unsure whether there's a adenoma in the pituitary, then sometimes there may be a tiny lesion in the pituitary that's not seen in the MRI, and you have to differentiate between whether this is from the pituitary or is from the ectopic. So then you have to do this IPSS testing, and in the IPSS testing, if in the petrosal sinus ACTH levels are high, then you are assured that this is coming from the pituitary. Whereas if it is low, or if it is say equal as periphery, then it means that it is not because of a pituitary tumor. It's probably coming somewhere from the ectopic areas. Then you may have to do a CT scan or an MRI of the chest, or sometimes nowadays we do a somatostatin receptor scan such as a DOTA PET CT and so on.
That means only when it is not detected by other sources of investigations, you go for intrapetrosal
Exactly.
sinus.
Yes.
Okay, thank you. Thank you.
Thank you, sir, for
Thank
your
you,
patient's
sir.
response.
That was a detailed evaluation of your the hypothalamo-pituitary adrenal axis, and you gave us a very good insight about the importance of static and dynamic tests. I'm sure most of the undergraduates would have been benefited by doing that stepwise assessment of endocrine disorders. It was well appreciated, and the causes of primary and secondary adrenal insufficiency. I'm sure there are a lot of postgraduates also here, sir. So they must be finding it very useful, and the various tests which you gave us for the evaluation of the HPA axis was very good. Thank you for the detailed lecture.
Thanks.
Thank you, ma'am. I request Dr. R. Shanmugavadivu, ma'am, to felicitate the speaker. Now I call upon HOD Dr. N. Deepalakshmi, ma'am, to felicitate the chairperson. Thank you, ma'am.
Challenge yourself to unlock the mysteries of biochemical interactions and molecules of reactions. Okay, let's see the quiz. Okay, your first clue is Peripheral smear shows the nucleated RBC. Target cells and poikilocytes are seen. And your next one is, it also called Kudith. And you got it, I think. It is a quantitative hemoglobinopathy. Any guys have a try, please? Have a try.